Oh, I'll be over and well within the time. This is the front sheet of this year's version of the EU guidelines on male sexual dysfunction, focusing primarily upon erectile dysfunction and premature ejaculation. The EAU guidelines in this area were first published in 2000 and have been updated regularly since, and I've been on the guideline committee since about 2009. I've just demitted, so it's somebody else's job going forward. The 2015 update had a new section on Avanafil. It had been restructured in line with the oncological, with the other non-oncological guidelines, and one of the main drives this year was to reduce the word count by about a third. That's one of the big jobs we had to do this year to make them far less verbose. There's two main bits. There's an awful lot of text in the EAU guidelines, but there's two bits that really focus what the guidelines say. The first one is there's a series of algorithms, and then there's a series of tables with recommendations, which you've seen in some of the other presentations. This summarises the algorithm for the minimal diagnostic assessment of a man with erectile dysfunction. And it talks about things that I think will be familiar to everybody in the audience. This, I think, reflects fairly standard UK practice. So in terms of the history, you have to identify other problems than the erectile dysfunction that might have caused the ED, identify common causes, identify reversible risk factors, and assess the psychosocial status of the individual. In terms of examination, the guidelines say that we should be examining the prostate, checking for penile deformity, signs of hypogonadism, and assessing in a focused fashion cardiovascular and neurological status. I think the one comment I'd make at that point is the routine assessment of prostate disease is not something that I do. Just moving briefly on to the investigation, I don't know how many you will have picked up in the recent NICE guidance about diagnosis of cancer that it's recommended that all men presenting with erectile dysfunction should have a PSA test, and that's something perhaps we could debate. Moving on to investigations, the EAU guidelines say that all men should have a total testosterone. That's by far the easiest assessment to measure rather than a free testosterone. They should have a fasting glucose and a lipid profile. And that's what the guidelines say we should do. In terms of specific investigations, they suggest that there are a number of patients who do require specific diagnostic tests, unusual sorts of cases, perhaps not the sorts of cases we see very often, men who've never had an erection, men who have a history of trauma where you might be looking for a vascular cause. Interestingly, when men have had a penile deformity that might require surgical correction is in the ED guidelines, and that really impinges upon what Roland was just talking about. Men with significant psychiatric problems need a psychiatric assessment. Complex endocrine disorders, I think while most of us would be happy to test testosterone and perhaps for prolactin, if it gets more complicated than that, we'll need an endocrinologist. We've all got the patients who want the tests doing because they want to find the organic reversible cure, and we sometimes do tests for medical legal reasons, and those are all in the guidelines. In terms of the recommendations, the first thing that strikes you about the assessment of a man with ED is how low the level of evidence is for all these recommendations. They're all grades 3 or 4, which is poorly controlled, these uncontrolled studies, cohort studies, or expert recommendation. So the grades of recommendation are really rather poor, and it's rather interesting that largely speaking it reflects what UK practice is. So comprehensive medical and sexual history is needed. Use of validated questionnaires may help to assess specific areas and assess effects of therapy. Examination to identify underlying medical conditions, the routine tests, testosterone, glucose, and a lipid screen, and the specific diagnostic tests are in only a few patients. And that, I think, may reflect a British practice. There is one of the inherent conflicts of the EAU guidelines is that the healthcare systems across Europe are different. In other parts of Europe, where there's a fee-for-service system, there's a tendency to do more tests. But that's not what the guidelines say, which are very more goal-orientated, and I think largely more in keeping with a British practice. Moving on to the treatment algorithm, in terms of the treatment, the reversible and curable causes should be identified, risk factor modifications should be identified and treated, and obviously patients and partners should be counselled. And then following those three things, the needs of the patient are identified and there's shared decision making about specific treatments. And in terms of those treatments, in the algorithm, it would appear that the PD5 inhibitors appear to be of equal priority in terms of degree of intervention with other more invasive treatments, intracavernosal injection therapy, pumps, or intraurethral or topical therapy. Topical therapy entered this year. But after that treatment, there's assessment of the therapeutic outcome, and if the treatment has failed, then move on to either one of the other treatments or combination of therapy. And if that fails, then perhaps you end up with the third-line treatment of a penile prosthesis. So, in terms of the recommendations, the table, what you notice here, firstly, is that for those treatments, the level of evidence is stronger. And that, I think, reflects in large part the existence of randomized controlled trials demonstrating efficacy of many of the treatments that we currently use. There is good evidence that lifestyle changes and modifications are beneficial. There is, interestingly, particularly in view of the debate I'm going to have with Francesco later on, a recommendation that pro-erectile treatments have to be given at the earliest opportunity after radical prostatectomy. If a curable cause is found, it should be treated. And then there's a clear statement that PD5 inhibitors are first-line therapy. Inadequate, incorrect prescription and poor patient education are the main causes of lack of response to a PD5 inhibitor, and I think we'd largely agree with that and reflect that in our practice. And then use of second-line treatments, pumps and injections, and penile implant being a last resort, third-line therapy. Moving on to premature ejaculation, again there's an algorithm, and this summarises that algorithm. The clinical diagnosis is based around primarily a history, making the diagnosis with the three prongs of the diagnosis, that is difficulty in control, it's the delay, the intravaginal ejaculatory latency time, and the bother. But then, in the history, it's recommended that the onset and duration should be assessed, psychosocial issues assessed. The bits about the physical examination and the investigations are very poorly documented, and the reality is there's no evidence that physical examination or investigations have any role in the assessment of a man with premature ejaculation unless you suspect a specific cause such as thyroid disease. Treatment is based around counselling, discussion of options, and if there is coexistence erectile dysfunction, then it's recommended that the ED is treated first before moving on to the premature ejaculation. And then in terms of treatment, pharmacotherapy is recommended as the first-line treatment for those men with lifelong PE. Ideally, dupoxetine, if it's available within your CCG, but off-label SSRIs, which paradoxically are available from most CCGs, are regarded as second-best treatment, even though they're unlicensed. And then also in that column, in the algorithm, is behavioural therapy and combination therapy. Moving on to the recommendations in the table, diagnosis and classification is based upon the medical and sexual history. The history is primary in the assessment of a man with PE. Clinical use of the intravaginal ejaculatory latency time is regarded as being adequate. Use of stopwatches has obvious problems and is not recommended as being necessary for most men, and what the patient tells you is recognised as being reasonably accurate. PROMs may have a role, physical examination may be necessary, routine lab investigations not recommended routinely. In terms of the treatment, these are the levels of evidence supporting the various sorts of treatment. ED to be treated first has a reasonable level of evidence. Pharmacotherapy first-line treatment for lifelong PE, that's what most of the trials show with dupoxetine, and that covers the use of dupoxetine or off-label SSRIs. There is data for local anaesthetic agents, although we don't have any licensed at present, and behavioural therapy has some evidence, but what evidence does exist that suggests it's best used in combination therapy. In terms of the specific treatments, that again is the levels of evidence and the grades of recommendation, with better evidence available for the SSRIs and for the local anaesthetics, and lower levels of evidence for on-demand use of PD5 inhibitors. So what's my commentary on all this? I've really just run through the EAU guidelines. And the reality is it's really very difficult to judge what UK practice really is. Largely speaking, those guidelines reflect my practice, but perhaps they would do, because I was on the committee that agreed them. But I think it is my observation that, largely speaking, they are in line with UK practice. There's been no British guidelines since 2007, and they broadly agree. The BSSM guidelines are largely similar. And if you go and look at the map of medicine or NHS choices, they largely reflect the EAU guidelines. As I've already suggested, it is interesting that those guidelines largely reflect a goal-operated approach to the management of man with ED or premature ejaculation, rather than reflecting the differences in healthcare services and their funding across Europe. Overall, I think it's my view that those guidelines largely mirror UK practice in both the assessment and the treatment of both erectile dysfunction and premature ejaculation, and I think provide a very useful guide to practice in this country. Thank you very much.
As you say, plenty of time for questions. Thank you. Any comments from the floor? Does practice vary between here and Italy, would you say?
We are still seeing a large number of tests being done in urological offices that are not really changing what will be done to that specific patient. I'm thinking about erectile dysfunction, where I still see a large number of penile Doppler studies being done. That is part also of something very peculiar in my country, where the practice there, Chris, would be mainly private. And so clearly there is an interest also of, from the urologists to do those type of tests.
Okay.
Please, number 2.
I appreciate this may be going on to a different topic, but in terms of erectile dysfunction and treating borderline testosterone, is there any evidence for the 8 to 12 or 10 to 12 group?
There's nothing in the EU guidelines about the testosterone management. The recommendations about 8 to 12 come from a multi-society consensus document that was published, I think, when Francesco was editor of European Urology, and encompasses experts from EAU, AUA, ISSM, and so on. And it's based upon expert opinion, primarily. The evidence base, I think, is limited. The best evidence comes, I think, from a study done by the endocrinologist from Munster, whose name escapes me, where he very clearly demonstrated an association between different levels of testosterone and different sexual symptoms. And that, I think, provides the best evidence base. It's not randomized controlled trials on any level.
Ian, is now in the UK, are all the PD5 inhibitors approved so that you can prescribe whatever you want?
They're all approved, but you certainly can't prescribe whatever you want. Since sildenafil lost its patent, the price went down, and the NHS changed the prescribing regulations so that all men are now entitled to receive generic sildenafil from their general practitioner without having to seek secondary care. So that's available on the NHS, reimbursed up to about 1, perhaps 2 tablets a week for some people. We have a commissioning system in this country run by things called CCGs, clinical commissioning groups, and they have taken a varied view to what to do with second-line therapies. Many of them, as I think we heard this morning in one of the presentations, have gone for Avanafil as the recommended second-line treatment because it's cheaper than the others. It's less expensive, and so the CCGs have made that recommendation purely on the basis of cost. You and I know that Avanafil is really very, very similar to sildenafil, and so one could debate that.
We had an excellent presentation earlier from Michael Fraser, and certainly you've touched on the guidelines. Now, the guidelines always lag behind the cutting face. Do you see anything on the cutting face at present?
The things that I think we've got to look at, Mike was a bit dismissive of shockwave therapy. I think there is some good data there from good units suggesting that it might be beneficial. The difficulty is all the good data comes from a single unit. I think we need to see other units reproducing that sort of data. And we need also to, having had one machine with data, if you go around the exhibition, there's about 3 different machines out there. And I think whether they are all the same, whether they all have the same efficacy, I think is yet very debatable. But shockwave therapy might come along.
Thank you very much, Ian.